This beautiful painting by Peter Bruegel is called Children's Games. It's very good for this article, and I think it's a marvelous piece of work. Well, what's the news about kids with stones? Here I've put in a group of reviews. Anybody who's that enthused can click on them. They all say about the same thing. They're becoming more common among children than they used to, and the children in general form the same kinds of stones as grown-ups do. They need the same kind of surgeries, but because they're smaller, the surgeons often have to have special skills and instruments. Very importantly, genetic causes of stones tend to occur much earlier in life, and therefore they're found among children. Finally, really important news. When you do urine studies in children, there are differences in their stone risks than from adults. And that's one of the main findings that I'm going to tell you about. It's really critical to be able to count stones accurately, because it's the only way to know if new ones are forming. This big article, which has a link, goes over the whole business of how to do it. And you can see from the link itself, CT images are crucial. Ultrasound is not very sensitive and it's not very specific. In children, until very recently, you could hardly ever do CT scans because radiation is just not right for kids. But ultra-low dose scanners are now here. And they hold radiation to the bare minimum. So even though a careful history and inspection of old records should be a big deal for figuring out stone counts in kids, you can do occasional ultra-low dose CT and deliver very little radiation. Something else about kids. Crystal passage with pain and bleeding, though it can occur in adults, is very common among children. It's well known to be associated with hypercalciuria. I think those episodes count as stone episodes, especially if the doctor checks to look for crystals in the urine. Two genetic causes of stones, renal tubular acidosis and cystinuria, are already featured on the site. Primary hyperoxaluria, a very serious problem that can cause kidney failure, can present with childhood stones or even kidney disease, and we need an article on it that I have not yet written. There's a very wide range of extremely uncommon genetic disorders that can cause hypercalciuria and stones in childhood, and they should have their own article as well. I need to do this, as I said before. What all this means is that every child with stones needs a pediatrician to make a very careful evaluation clinically to be sure that there are no systemic diseases present, particularly the genetic ones. Most of the time they're not. Most of the time they're idiopathic calcium stone formers. And I'm going to devote the rest of this article to that particular very large group. One of the first things you should ask, for the majority of kids who have idiopathic stones, how about recurrence? That means after they form one stone, are they likely to form more? The study of 285 kids with an average age of 14 says they surely are going to form more. Now, 0 along this line is in time, that's years, after a first kidney stone. And this is the proportion or fraction of kids who have not as yet had another stone. Look at this. It's 50% have formed another stone. We're about 3 years, and they keep doing it. By 5 years, about 75% have formed a new stone. So a child who has a new stone, a first stone, needs to get evaluated and treated. Otherwise, they're going to form more. In that study, the doctors tried to get 24-hour urine testing for every child. They succeeded in about 196. They failed in 89. This is the children with symptomatic recurrent stones after their first stone. This is the group who got the urines. This is the group who didn't get the urine. Now, this is clearly less recurrence than that. The difference doesn't look as exciting, but if you actually do the calculation, there's a 60% reduction of stones overall in the kids who got tested. There's something else nifty about this work. A lot of the kids in both groups got different kinds of treatments, thiazide, potassium citrate, whatever. If they didn't get the urine and got drugs, there was no effect. If they got the urine and got drugs, there was an effect. So what that means is getting treated with 24-hour urines works in kids. Getting treated without guidance, no urine study, doesn't work. And not getting a urine at all gives you a worse outcome. The message, like I say for adults, get 24-hour urine testing. Aim your treatment at the abnormalities that are found, and all will be well. Now I'm going to show you a beautiful piece of work that my partners did when I owned Litholink. We won NIH grant money to do a national survey of 24-hour urine stone risk in children. And you could read what's on the screen. A group of practices collaborated, and I give the numbers here of how many boys and girls we were able to study. This graph is the key, and I want to explain it to you. This is urine calcium excretion, milligram per day. You're used to that. You've seen it a million times on this site. This is just a percent of samples, so it's a kind of distribution of values. Right here, this dark line shows all the children who were true controls. They had no stones, and they came from families where there was no stone disease. These dots are the siblings, the brothers and sisters of the children who had calcium idiopathic stones. Next to them are the stone formers in those families who had 1 to 2 stones each. And next to them, the boys and girls who had more than 2 stones. The message could not be more obvious. If you go all the way from true normals, no stones, no family history, through to the siblings who had no stones, to the siblings who had, or the children who had 1 to 2 stones, and then the ones with lots of stones. Urine calcium is a graded risk factor. I don't know if you remember 200 milligram a day, but 200 milligram per day is the beginning of risk among adults. For children, it's obviously lower. About 150 is the mean here. This graph is just a bar graph showing the very same thing, but instead of all the individual points, it just gives you the means. The normal kids with no stones and families with no stones have a really low urine calcium, under 150 milligram on average. The siblings are appreciably higher. That's what the hash mark means. They're higher than these because they're hereditary hypercalciuria. Those with 1 to 2 stones, same inheritance, but they have the worst of it. They have more than these normals, and they have more than these kids, more than their siblings. These people, they have the highest of all. They have more than their siblings, and they have more than these. So as you go up the ladder in stone severity, you go up the ladder in hypercalciuria. Mind you, this is a hereditary trait. So what we're seeing here is varying expression of the trait. The worse it is, the higher the calcium, the more stones there are. Well, wait a minute, you're going to say to me, that's true for grown-ups. More calcium, more stone risk. So kids are just like grown-ups. But what about oxalate? Surely that's a risk factor. Answer: no, it isn't. These are the normal kids, the siblings, the stone formers. None of these are different. Their confidence limits overlap. What about urine volume? Absolutely not. These are normals. These are stone formers, siblings. They overlap. What about citrate? Surely it's much lower in the stone formers. No, it's not. These are normal kids, siblings, stone formers. This bar is lower than that, but these ranges mean there's a lot of variability. So no. Calcium phosphate stones are real dependent on urine pH. Is it higher in the stone group? No, these bars all overlap. What about phosphate? That could give you phosphate stones. No, it's not higher in the stone formers. So there are no other stone risks in the urine of children with idiopathic calcium stones. It's just hypercalciuria. And that hypercalciuria is genetic idiopathic hypercalciuria, which a vast majority of routine idiopathic stone-forming adults have. So the kids are like the adults, all right. They have the hypercalciuria, but they differ because they don't have any other reason for their stones as a rule. I don't mean to say that some kids don't have high oxalate. I don't mean to say that some kids don't have low citrate. I just mean as a rule, it's all hypercalciuria. If you're reading the article, you'll notice I've skipped over a couple of sections because I want the video to focus on the main points. If you want to hear about those missing sections, stick around and it'll be at the end of the video. So what do we do with kids who have stones? First and foremost, they have to have pediatricians who are skilled and will see to it that they don't have any important genetic causes or systemic diseases. That's their job, and it's beyond the range of this site. You might say idiopathic hypercalciuria is a genetic disease, but it's really a trait. It causes stones and bone disease, but diet management should be enough. So after they've been evaluated and you know the kids simply have hypercalciuria and routine calcium stones, you treat them as you would adults with the ideal diet. That diet has the low sodium, the high calcium, low refined sugar, high fruits and vegetables, and that combination will greatly improve the hypercalciuria. You've read elsewhere on the site, as you lower the diet sodium, the urine calcium will go down. That allows you to raise the calcium, which is good for bones. Sugars cause bursts of calcium loss, so you don't want the refined sugars. Fruits and vegetables give you extra citrate, which is healthy. Now, oxalate always comes up, but remember what I've said elsewhere. High calcium diet drops urine oxalate because it blocks oxalate absorption. So what you want to do is the low sodium, high calcium first. Then look at the urine oxalate after that. If it's still a little too high, well then get rid of the highest oxalate foods. That should usually do it. If the diet can't control the urine calcium and the stones continue, then you're into thiazide or potassium citrate. That's like in adults, but very critical in children. That's something your physician has to take care of for you. Now at this point, those of you who've had enough should leave. After this, I'm going to go back and teach about supersaturation in children 24-hour urines and other matters that you probably wouldn't find that interesting. Okay, those of you who stuck around, this is the supersaturation story in children. Here is calcium oxalate supersaturation. It's the lower end of these bars. As you might expect, the normals are lower than the siblings, and the siblings are lower than the stone formers. If you take the normals here and compare them to the siblings, and then to the 1 to 2 stone people, And then the greater than 2 stone is a continual progression. And that's because the urine calcium is going up. For calcium phosphate supersaturation, the bottom of the graph, exactly the same story. Goes up and it goes up. Stones make it worse. But what's the top of the bar? The top of the bar is the upper limit of metastability. That's the supersaturation at which crystallization occurs. You get this experimentally in the case of calcium oxalate by adding oxalate to urines and finding out the supersaturation that creates crystallization. You see, it goes up just like the supersaturation. So in other words, as the floor goes up, the ceiling goes up, which means the higher supersaturation is being offset by a higher and higher threshold needed to crystallize. This is a tremendous protective effect. It occurs in adults and children. Even so, supersaturation is a big risk factor. For calcium phosphate, the upper limit of metastability, the point at which crystallization occurs, is determined by adding calcium to raise the supersaturation till you see crystals. Here we see something really interesting. It does not go up and up. It goes up definitely in the siblings compared to normals, but for those with stones, no. That means these come closer together, and that's a risk for crystallization of the phosphates. If you take the big groups, the normals, the siblings, the 1 to 2 stones, and the greater than 2 stones, it's really something. Look at this. These are almost on top of each other. Now you might say, really, who cares? Here's why to care. It's calcium phosphate crystals that trigger off the crystallization cascade. You'll find that all over the site. I didn't put it in this article because the article is not meant to be that technical. I think what's happening is the calcium phosphate gets crystallizing here, and that sets off the stones. Well, that's the technical part. You've waited around for it, and I admire you. Now it's time to sign off, and thank you very much for sticking around.